Just like there are layers in the cornea, there are layers in the sclera. So how many layers are there in sclera, everybody? We say there are only 3 layers in the sclera. The first layer, everybody, is called as episclera. If you're smart enough, if you've understood cornea, if you've listened to me at least, then you know episclera, epi means out, everybody, yes? So this must be which layer of the sclera, everybody? Outermost layer of the sclera. This is a densely vascular layer. Number 2, everybody, comes sclera proper. Okay. This is a mainly avascular layer. And thirdly comes the innermost layer. Obviously, if episclera is my outermost layer, the third layer has to be the innermost layer, guys. Yes or no? So the third layer is lamina fusca. I am writing here innermost layer, everybody. Yes, that is the only question per se that they can ask you on lamina fusca. What is the innermost layer of sclera? Because it is a fancy name. Yes, they can ask you lamina fusca is, or what is the innermost layer of sclera here. Now, understand, everybody. Episclera, I have said, is a densely vascular layer. And it has 2 groups of blood vessels. I can say one is a superficial blood vessel. Okay. One is a deeper blood vessel. Even though it is part of an episcleral densely vascular structure, but it is nearer to the sclera proper because it is deep. Okay. So we end up having 2 conditions. If we say the superficial vessels are inflamed because they are near to the episclera, we call that condition as episcleritis. But if it is an inflammation of the deeper blood vessels, so we say that it is inflammation near the sclera proper. So we change the name and we call it scleritis. Okay. I know it is confusing. Even though I've said sclera proper is avascular, but still I'm saying scleritis. Because the deeper vasculature is near the sclera proper, that is why we say that whenever the deeper vasculature gets inflamed, it is scleritis because more of sclera proper is getting inflamed. Yes? Now, let us understand episcleritis and scleritis and the differences between them. Okay? In sclera, per se, there is no other pathology. This is the only pathology, guys. Episcleritis or scleritis. What is the treatment? How to differentiate? And that is all I will be teaching you about sclera. So this is the anatomy of sclera getting discussed as well as the pathology of sclera. So you won't find any chapter named sclera in your whole video list here. Okay. Now, episcleritis versus scleritis. What is the challenge here? Understand. Episcleritis is also inflammation. Scleritis is also inflammation. And this is an inflammation at last of the parts of the sclera. So what will be the basic appearance or what will be the basic complaint of the patient in both the cases? The patient will say that I have some redness. Yes. Redness means the patient will say the white part of my eye has become red. In episcleritis also the patient will complain of redness, as well as in scleritis the patient complains of redness. So how to differentiate? That is where the knowledge that I have just given you, everybody, that episcleritis is of the superficial layer inflammation and scleritis is a deeper vasculature inflammation. That is where it helps us. Let us see how, everybody. Let me first write. Episcleritis is inflammation of superficial episcleral plexus, whereas scleritis is inflammation of deeper vascular plexus. Now, through anatomy, I hope we know, basic anatomy, first year, everybody, that the superficial vessels always appear reddish, have a reddish hue, whereas the deeper vessels, because of their deepness, everybody, they appear bluish or violaceous in color. So what are we saying? That on examination, ideally in episcleritis, there should be a reddish hue. Okay. But in scleritis, because now the deeper vessels are getting inflamed, there should be a bluish, or the better word actually is violaceous hue. The importance here is deeper vasculature or the superficial vasculature. Okay? But what do we end up seeing? Almost always we see whether it is episcleritis or scleritis. It is very difficult to differentiate based on the color, reddish or violaceous. Everything looks kind of the same. There are very rare cases where you are able to differentiate frankly. That means just based on this theoretical anatomical knowledge, we are not able to differentiate. So that means there should be a test, everybody. So what are we using? We are using vasoconstrictors to be able to diagnose this. Based on the phenomena of what? That whenever we give vasoconstrictors, the blood vessels constrict, and due to that, the congestion disappears. Now what is congestion, everybody? See, why does redness appear? Why do you see redness? Are there no blood vessels in my sclera? There are. But when there is congestion means traffic, everybody. The blood vessels are filled with all the blood due to vasodilatation, XYZ inflammation. You are able to see that blood more. That's why you say you have redness. When I give vasoconstrictor, all the blood vessels constrict, the blood starts flowing, and the redness disappears. So this is what we call as vasoconstrictor test. So we say episcleritis, redness disappears after 2.5% phenylephrine eye drop instillation and we call it as blanching. Whereas because it is a deeper plexus, everybody, in scleritis which is inflamed, and vasoconstrictors is going to only act on the superficial surface, superficial blood vessels. In this case, we say there is no blanching. That means the redness does not disappear. The redness or the violaceous nature does not disappear. Okay? So if you are confused based on the color whether it is episcleritis or scleritis, you just simply use 2.5% phenylephrine eye drops. If the redness disappears, that means there is blanching, everybody. That means you are confirmed it is the case of episcleritis. But if it does not disappear, that means it has to be a case of scleritis. There is another clue which can help us differentiate between scleritis and episcleritis, everybody. In episcleritis, the patient does not have any tenderness whatsoever. But here slight pain or tenderness is common, or I am saying is present. Okay? Are we clear about this? Lastly, the question that comes into my mind is whether I have been able to differentiate based on the color or based on the phenylephrine vasoconstrictor test. At last, it is inflammation. So for inflammation, I will have to give either steroids or NSAIDs. In both the cases, episcleritis as well as scleritis. Why am I trying to differentiate between both these conditions? Both these conditions are inflammation at last of the sclera presenting in the same way, blah, blah, blah. Yes, we are trying to differentiate between both these conditions because this is usually idiopathic episcleritis, whereas scleritis is commonly found to be associated with diseases such as rheumatoid arthritis. So we know that if we are seeing a case of scleritis, we may actually be looking at a sign of impending rheumatoid arthritic changes which develop in the patient's body, everybody. That is why it becomes important to be able to differentiate between a case of episcleritis and scleritis. Now, let us see the images and let us try to answer. Very easy to answer if you have understood, everybody. So we have two images, image 1 on the left side of the screen and image 2 on the right side of the screen. Can you tell me what is image 1, episcleritis or scleritis, everybody? It is frank red, everybody. Yes, I know it is episcleritis. But if I see the right image, everybody, image number 2, I see there is some bluishness occurring or bluishness skin. That means I must be looking at a case of scleritis. But as I explained to you previously, everybody, this is very rare to see such easy cases of scleritis and episcleritis getting differentiated. But I hope if you are asked in an image, these are the kind of images that you will get and not only red color. And based on that, you will not be able to differentiate between episcleritis and scleritis. Okay. Moving further here, everybody. Scleritis can present in various forms. So episcleritis we are done with. So we said types of scleritis. Types of scleritis can be A, anterior non-necrotizing. Second, anterior necrotizing. Necrosis is also occurring. Now this anterior necrotizing is the more worrying part. Anterior necrotizing can be divided into two parts. With inflammatory change is visible, with inflammation. Or we say that actually there is scleritis occurring, but you don't see any inflammatory changes. This is what is difficult to diagnose. This is known as scleromalacia perforans or perforans. Because you don't have any symptoms in the patient, you don't have any signs of inflammation, everybody. That is why the diagnosis is typically late. Yes, you have a completely white eye, if I say. There is no redness, no bluishness, everybody. And it straight away leads to perforation of the sclera because of the continuous inflammatory changes which are not seen, but which are leading to thinning of the sclera. Yes, there is no vision affected, nothing. But at last, the problem will be sclera can be perforated. With inflammation, everybody, these cases are easy to diagnose. They can be associated with rheumatoid arthritis, or they can be associated with conditions such as Wegener's granulomatosis or even polyarthritis nodosa. Okay? And that is why I say scleritis, it is important to diagnose and differentiate from a case of episcleritis. Right? Now, moving on, everybody. We have discussed the layers of the sclera. We have discussed the diseases. We have discussed the thickness. To end with the basic anatomy of sclera, everybody, let's see what are the openings or apertures in sclera. Sclera is the outermost layer. So for things to come inside the eye or go outside the eye, there have to be some openings. So the first opening is a very important opening, and that we call as lamina cribrosa. Lamina cribrosa is a sieve-like opening to transmit the optic nerve. Okay. If you understand, I hope you will be able to remember this just by here. If you don't, let me just draw the posterior segment of the eye. See, this is my retina, yellow colored, as we had drawn. This is my choroid, everybody. And this is my sclera. So the diagram that we had drawn, everybody, these are the colors that I had used. So I know that optic nerve is formed by the fibers of the retina. So all the fibers of the retina have to go out. But to go out, we have the sclera in between. So we say in this area, sclera forms a sieve-like opening through which all the fibers of the optic nerve are able to pass. Am I making myself very clear here, everybody? Yes. And this opening in the sclera posteriorly present. So I can write here, everybody, posteriorly present is known as lamina cribrosa. It has other openings also. In the middle, everybody, 4 to 7 mm posterior to the center of the eye, that is the equator, posterior to equator, to transmit vortex veins. And it has opening anteriorly for anterior ciliary artery and nerves. Okay. We will read in the blood supply of the eye that anterior ciliary artery pierces the sclera 3 to 4 mm posterior to limbus in the anterior part of the eye. Okay. So these are the three openings that we find in the sclera. And that is all about scleral anatomy from my side, everybody. Short and sweet. As I said, cornea is much more important because it is transmitting light. So we know that there is any problem in the cornea, everybody, it will lead to loss of vision. But there is no loss of vision associated with scleral problems, because sclera has nothing to do with transmission of light per se. Now we are done with two parts of the outermost layer, everybody, cornea and sclera. We are left with the last part, the junction, everybody, and that was known as limbus. Okay, so let's read a little bit about the importance of limbus, corneoscleral junction. So the first question that I like to ask everybody is, cornea and sclera are touching each other. Okay, thousands of things touch each other in the body. Do we give everything a name? The answer is no. Why have we given the corneoscleral junction a name? And that is where the answer lies. And that is where the importance that gets stuck into your head lies. If I am giving a junction a name, we must be giving it a name because it holds some significance. An anatomical, a surgical, a pathological, some kind of significance must be there. And that is what the question is. What is the importance of limbus? What is the importance of corneoscleral junction? So the importance is an answer of pathology. What is the answer? If you remember pathology, limbus contains an important type of cells which are called as stem cells. Yes, I know all of you have heard of stem cells. What are stem cells? What are stem cells? What are stem cells? Yes, stem cells are called as pluripotent cells or totipotent cells. What is the literal meaning of, what is the function of stem cells? Pluripotency. What does it mean? What does it mean? Yes, you are saying, a lot of you are saying, I know, I can hear you. Even though I can't literally, but I can hear you. Lot of you are saying that these cells can regenerate. I say you are saying absolutely wrong. That is where the difference of English comes in. See, what does regeneration mean? Regeneration is an entirely different concept. Even a bacteria can regenerate by performing mitosis. So when I say regenerate, I am basically saying that right now there is one Dr. Utsav. If I regenerate, I will become 2 Dr. Utsavs. Then I will regenerate to become 4 Dr. Utsavs. Then I will become 8 Dr. Utsavs. But stem cells are not merely regenerating. They are, yes, that is the word, if you understand, ability to differentiate. So instead of regenerate, we are using the word differentiate. What do you mean by differentiate, everybody? That I am a stem cell, Dr. Utsav. If I differentiate, instead of an ophthalmologist, I will become a pharmacologist. I will change my specialization. I have the ability to do any specialization. So Dr. Utsav differentiates to Dr. Ranjan, differentiates to Dr. Sakshi, differentiates to Dr. anybody. Okay. So basically I can become anybody. I can become Dr. Rohan. I can become Dr. Ela. I can become anybody. I hope you understand what we are trying to say here. Yes. So what is the importance of stem cells in the eye? Let's say I have trauma. I have trauma to my cornea. Some corneal aberration, some corneal defect. How does the cornea repair? So stem cells from the limbus will migrate to the cornea and they will differentiate into corneal cells, everybody. And thus I will have healing. Similar can be said about sclera. So they are helping us because of the ability to differentiate, not regenerate. I hope you get the concept in your heads. Yes? Now, where are the stem cells located? Now questions on stem cells, everybody. So where are the stem cells located? So we say the location is epithelium in specialized areas which are known as palisades of Vogt. So in the epithelium at the limbus, in specialized areas, palisades, where there is stacking of cells, everybody. Palisade means stacking, palisades of Vogt. Now, the next question that the examiners have asked previously is, what is the specific marker of limbal stem cells? This question has actually been asked twice in your AIMS examinations previously. Specific marker of limbal stem cells, that if you want to find out where are limbal stem cells located, everybody, what is the specific marker which only will find out the limbal stem cells? The answer is ABCG2. Okay. But there can be another question, everybody, pathology question. What is the universal marker of stem cells? I hope you understand the difference between the two questions which I have asked here. Specific marker for only the limbal stem cells, but stem cells can be present at a lot of other places in the body. So what is a universal marker which you can use everywhere to find out the stem cells, everybody? The answer is cluster differentiation factor 34. I know a lot of you know this through pathology, everybody. Yes? Done? Are we clear about this? Now, one last important question which I think may be asked on limbus to you is, can you tell me a limbal stem cell deficiency disorder? If there is deficiency of limbal stem cells, what kind of pathology can it lead to? It is a very common name. It is something which you have all of read, all of you have answered daily in your vivas, but you don't know this concept. You don't know this fact, I will rather say. The answer is, yes, I know you may be slightly amazed at hearing the answer. The innocuous pterygium, everybody. We have read in our books that pterygium is due to UV exposure, heat, blah, blah, blah. All those are risk factors, yes. But at last, the pathologic basis of pterygium is deficiency of limbal stem cells, which leads to overgrowth of conjunctiva over the cornea. If you don't know what is pterygium, please, obviously it is discussed in detail in the conjunctiva video lecture, everybody, right? And that's all about limbus from my side. That's all about the outermost layer of the eye, the three parts, the cornea, sclera and limbus in detail. Lots of questions are asked from it. There are concepts in it. There are importances of it. And we use these concepts and importances to be able to build on our knowledge, to be able to solve pathological questions, as we have actually already seen in sclera, how we have used the basic anatomy and the basic pharmacology to be able to differentiate between episcleritis and scleritis.